Good afternoon, everyone. Just my disclosures to start with. So over the next 25 minutes or so, I'm going to give some introduction, thinking about telemedicine with regards to hypertension. I'm going to give some quite reasonable detail about the 2 UK trials of self-monitoring that have used telemonitoring. First, Paul Padfield and Brian McKinstry's trial around HITs, and then our work in the Tasman 2 trial, which was involved self-management. And then we'll try and come to some conclusions. So just thinking in terms of what the prerequisites are if one is going to use telemonitoring in hypertension management. Well, the first thing is you've got to get the patients to self-monitor. So quick show of hands up who's got patients who self-monitor. Okay, so good, probably the majority of people. Then you've got to have a system to transmit the readings from the patient to the doctor or nurse. So hands up who's got a system for that. Okay, much fewer, but a handful of people. Then you need to access those records either through a web interface or through an electronic patient record, ideally through an electronic patient record. Hands up who uses electronic patient records in their day-to-day practice. Okay, so again, a minority of people. And then finally, most importantly, you've got to maintain the communication between professionals and patients, and we'll see that's not necessarily entirely straightforward. So, start with just a bit of background about self-monitoring in hypertension. It's been around for a lot longer than people imagine. It was first recorded in 1930 at the Mayo Clinic when a chap turned up with what I imagine was the precursor to an internet printout, which was 3 years of his own blood pressure measurements that he'd been doing. And he was described as an intelligent male patient of 25, and they noticed his blood pressure changed with diet, with the seasons, and it went up at the weekends, which they put down to the diversions of a young man, which I will leave to your imagination. The first trials in self-monitoring were done actually by Hayes and Sackett, which many of you will recognise their names from evidence-based medicine, but before they did evidence-based medicine, they did self-monitoring. And they started off using these sorts of fairly tricky to use self-monitoring kits. But then for about the last 15 years, we've had properly validated, accurate automatic SFIGs, which make life a lot easier. And in surveys in Europe and the US, the majority of patients in hypertension clinics, which are typically run by specialists, are self-monitoring. In the UK, in primary care, our surveys suggest around a third of people are self-monitoring. But interestingly, if you ask people if they've actually mentioned this to their GP or physician, only about half of them have. So interesting thing that there are people clearly going and buying monitors. In Japan, I'm told that there are now more monitors than there are households that have been sold. So, there are a lot of this kit about, and we don't necessarily realise that it's being used. So we have surveyed some GPs to find out what they think's happening. We surveyed them in 2011, just before the NICE guideline came out, and we've just surveyed them again this year, and both surveys we were supported by the BHS. The red figures up there are from the latest results, the black ones from the original survey. So most GPs, both in 2011 and now, had patients who self-monitor. More and more are buying monitors to lend out to patients, and interestingly, the proportion using self-monitoring in diagnosis, although we recommend obviously ambulatory monitoring in the NICE guidance, but the proportion using it in diagnosis has really jumped up since those guidelines. And telemonitoring is not widely available, but I think that's interesting to see how things have changed. One of the interesting things about self-monitoring is if you do self-monitoring on its own, this is from a systematic review that my colleague Emma Bray did, self-monitoring on its own has a small effect if you meta-analyse the studies. This is systolic blood pressure, 2.5 millimetre reduction. If you do self-monitoring with a co-intervention, of which more, you get about double the effect. So it's not just, self-monitoring is not magic, it's what you do with telemonitoring. So what do I mean by co-intervention? Well, in this instance, I'm obviously talking about telemonitoring, but also things like self-management, nurses, patient education, pharmacist input. And clearly you can do telemonitoring and these things. So when people talk about telemonitoring, it's not just straightforward. It may well be more than just transmitting the readings. So in terms of transmitting the readings, how do you do this? Well, you can use direct systems where the monitors either send the readings down a landline historically or more recently via Bluetooth to phones or Bluetooth or computers, which then automatically send the readings. So that's great in that you're fairly clear that the readings that are in the monitor are actually transmitted, and studies suggest that maybe about 20% of blood pressure readings that patients take, if they don't know you're going to look at the monitor's memory, never appear on any record that they give you. The disadvantage with these direct systems is that they're quite expensive. You've got to have Bluetooth phones, you've got to have a much more expensive monitor. So the alternative is to have some kind of text or app or website that allows the patient to simply add in their readings. There are novel applications coming that are integrated with people's phones. So this is the kind of thing. And the advantage that one can have is that you can send people messages. It's a welcome message from one of our trials. And when they send their readings in, you can thank them. If they don't send their readings, you can flag it. And if they have a high reading, I haven't shown it here, but you can say your reading's high, can you check it again? And then if it's still high, you can get them to do something about it. So that's handy. And then physicians and nurses can look at screens. This is again a screen from one of our trial databases, which flags up when patients get high or low readings, tells you what's been going on, tells you the mean, and so on, which is obviously very nice and potentially very efficient. Validated monitors are now available. This is a consumer model that one can just buy on the internet. And also, we've heard a bit about Apple earlier this afternoon and how things are starting to get integrated. EMIS, which in England at least supplies something like 60% of GP clinical informatics systems, is now integrated with this. And so we are bound to start seeing all sorts of things, not just blood pressure being reported by the patients. So the theoretical attractions of telemonitoring include, as we mentioned, feedback and the opportunity to intervene. It can potentially promote the doctor-patient partnership by linking those results and making sure that those patients who are monitoring have an opportunity to share their readings with their GP or physician. It does bring information management issues, because clearly if one is used to dealing with, say, 2 or 3 blood pressure readings every 6 months, that's quite a different amount of information than if someone's doing 28 readings a week and then giving you multiple weeks, and how do you cope with that? We've seen automatic feedback is possible. Also, because you're getting the readings sent electronically straight into a database, you can do things like look at blood pressure variability, which are very difficult to do otherwise. Potentially it can reduce carer burden. Families aren't having to bring them backwards and forwards. Say if someone's had a stroke or other chronic disease that makes life difficult, that can be very important. I suggest that you can get better control than self-monitoring alone, potentially, but we'll have a look at what the data is on that. So I thought that I would give you some details on the 2 trials that have been done in a UK setting. And I'm going to start with Brian McKinstry and Paul Padfield and colleagues' work on the HITS trial. So this involved a service redesign, including telemonitoring, to manage patients whose blood pressure was above target at baseline who were already diagnosed with hypertension. And the patients used a Bluetooth monitor like this, and they self-monitored for a week at baseline, and then after that they just did the blood pressure weekly unless their blood pressure was uncontrolled when they did a series of measurements again. They could opt in to a text or email for decision support, and about half of them in the trial did, and they randomised them to either this telemonitoring system or usual care, about 200 in each group, and they followed up nearly all of them with a primary outcome of ambulatory monitoring at 6 months. At baseline, they recruited people who were around 60, about 60% were men, and they had a BMI of around 30, so fairly typical hypertensive population. And they found, and their study was interesting because it was one of only, I think, 4 self-monitoring studies in the world literature that used ambulatory monitoring as their outcome. And they got 4/2 for their mean daytime systolic blood pressure reduction in the intervention group over and above the control group, and that was highly significant. So doing telemonitoring in this situation with the option of text feedback to the patients did seem to work. So why did it work? Well, it's probably due to better use, better targeting of drugs. So this is drugs at baseline, this is drugs at follow-up. The dark bars are intervention, the open bars are control. Green arrows is what happened to patients in the intervention group, red arrows is in the control group. So you can see that the number of people going from who were on 2 medications went up by quite a lot in the intervention group, much less so in the control group. The number on 3 went up in the intervention group, didn't really change in the control group. And it was similarly for the number going down who were on 0 and 1, but I haven't put arrows on because it made it too confusing. The biggest change that they saw was in calcium channel blockers. They looked at costs. It cost over the 6 months about £115, of which just over half was from the telemonitoring cost, and they used a Bluetooth system, so it's a relatively expensive intervention. £26 per millimetre mercury reduction, and this is looking at cost effectiveness. So it's expensive, but not very expensive, but nevertheless, thinking about this over and above what we're doing now, are we going to get politicians to pay? So the bottom line was there that self-monitoring with telemonitoring lowered blood pressure, probably through increased drug use, quite expensive. They didn't do modelling, and I'll show you our study where we did do some modelling just to show you what additional information that gives. So having seen what happens with self-monitoring and co-interventions, we wondered whether you could use self-management, in other words, self-monitoring with self-titration of antihypertensives, and whether that would work. And this has been done in diabetes for years, arthritis, asthma, and so on. Hypertension is different from some of these other conditions in that people don't necessarily feel, unless their blood pressure is very high, don't feel any different from having high blood pressure. So self-monitoring becomes very important. And at the time we did this work, there'd just been about 30 people randomised with very short follow-up of about 8 weeks, which was promising but not definitive by any means. So we did the Tasman 2 trial, telemonitoring and self-management and the control of hypertension. And we were aiming to see if such an intervention reduced blood pressure, whether it affected adverse events or health behaviours or costs, and whether it's achievable in routine practice. We randomised people aged 35 to 85. Again, they had treated hypertension and their blood pressure was above target at baseline. We included people who were on no more than 2 antihypertensives at baseline in order to give room to increase their medication if necessary. Individually randomised people. Practice GPs determined the management throughout, so we didn't have some specific algorithm. We made sure everyone had the up-to-date NICE guidelines, but they could use whatever drugs they wanted. Patients self-monitored for the first week of every month and using, at the time, a standard Omron monitor, and the results were sent through a telemonitoring system down a phone line to a database and then summaries to the GP. And the patients and GP could log on and look at their results, and each of these blue sets of bars is a week of monitoring, and so this is a year's worth of results. We used standard blood pressure targets, which were adjusted for the then standard 10/5. So we had 130/85 or 130/75 for people with diabetes for the home targets. And patients met with their GP at the beginning of the trial and agreed what you might describe as a recipe, what to do if their blood pressure remained above target. And they used a standard traffic light system, green, amber, red. Green meant their blood pressure was fine, they didn't have to make any changes. Amber was if their blood pressure was raised, and if it remained raised for 2 months in a row, they made a change without having to go back to their GP for the medication. Red was very high or very low, where we asked them to go and get their blood pressure checked with a practice nurse. We followed them up at 6 and 12 months. Again, we used systolic blood pressure. This time we used office measurement, which we did with a standard mean of 2nd and 3rd, but we also used a BP true to get a mean of the 2nd to 6th reading to try and give us a result that wasn't affected by habituation. We needed just under 500 patients to detect a 5 millimeters of mercury difference. We had integrated qualitative study where we did interviews with both patients and professionals, and I'm going to show you some results from the patients. This was done with pretty standard qualitative methods, and we analysed them using the constant comparative method. Our patients were a bit older than in the HITS trial, so mid-60s, and about 50-50 men and women, and systolic blood pressure was 150, just over 150 in each group. And actually, having done a couple of trials since this trial, it's quite difficult to recruit people with blood pressure this high, which I think is a reflection on how well, in general, blood pressure control has happened. We got, after 12 months, a 5.5 millimeter systolic reduction. It was also significant at 6 months, and we ended up with about 135 systolic in the intervention group compared with 140 in the control group. And you notice that the control group went down from 152 to 140. So things were happening in the controlled group. Probably some of this is regression to the mean, but some of this is also GPs looking after the control group. Most people managed to self-manage for the full 12 months. About 70% made at least one medication change. At 12 months, about half an additional antihypertensive medication was prescribed, and again the main changes were calcium channel blockers and thiazides, which is relevant when you look at the side effects, which were almost identical between the groups, apart from in terms of ankle swelling, which was increased in the intervention group, presumably due to the CCBs. In terms of costs, over the year of the trial, the intervention cost about £100 more, and that's taking into account both the intervention costs and the costs of any health service, things like consultations, outpatients, etc. And we did modelling this time, where we modelled the blood pressure difference over time, and we found that this was a very highly cost-effective intervention with ISAs of around 1,600 for men and just under 5,000 for women. NICE uses an ISA of 20,000 as their threshold. So this is really very cost-effective. The modelling depends quite a lot on the assumptions you make, and we found this to be cost-effective provided that blood pressure difference between the groups lasted at least a year. In terms of what the patients thought, they were generally pretty positive. They were surprised at the differences between their readings and the ones that they were used to in the practice. They observed, like we do, that blood pressure changes the more that you do it. They felt that the amount of self-monitoring they were doing was about right. They liked the sense of control. This is a quote from a patient who put his GP right on blood pressure monitoring, which I think is very good. They liked to take control, and it gave them a forum to discuss things with their GP. So I think that's interesting. So as in many conditions didn't particularly like taking their medication. It was a trial, and the adherence levels were actually very high, which is not uncommon because people who agree to take part in trials tend to be fairly adherent. They were more happy about making changes to their medication if they were substantially above target, and if they were only just above, they were much less happy about it. This is a lady who, in fact, did make changes, but was just over the target, and you could see she wasn't desperately happy about it. So, did they follow their instructions? Well, this is a graph. Each of these bars is increasing numbers of recommended medication changes. So this bar is people who were recommended 5 changes. This is those who didn't have to make any change. So of the ones that didn't have to make any change, none of them did make a change. So that's all green. As you can see, as the number of changes goes up, the green are the people who followed the rules the whole time, amber are people who followed the rules some of the time, and red are the people who ignored the rules. Okay, so you think on average about 55% of the time patients followed the rules. Now, do we think that doctors are better, higher or lower? What do we think? Higher? Or lower? Lower, okay. So American colleagues have done work and they had a trial where doctors were titrating on the basis of self-monitored blood pressure, and in that case it was 41% compared with 55% of the patients. They looked into this and said it was all down to good clinical judgment, or I would argue clinical inertia. Interestingly, in Japan, which I would have expected the doctors to follow the rules very carefully, the only trial in self-monitoring that's been powered to show a cardiac event difference failed because 25% of the people in the intervention group, 25% of the doctors, for the people in the intervention group, the doctors followed the rules 25% of the time, and then in the control group it was 27%. So they basically just violated all the trial protocol, and it didn't work at all. Complete waste of time. So bottom line is that self-management with telemonitoring results in significantly lower blood pressure. Increased medication again seems to be the main mechanism. It's cost effective. In our trial, telemonitoring was largely as a safety net, and we went on and did another trial of self-management without using telemonitoring and actually got better results. So there's an argument about how much the telemonitoring actually does. Patients are clearly happy to be more involved in decisions on their medication. So to put this in context, this is Stefano Omboni and Parati's systematic review of telemonitoring, and you get about a 5 millimeters systolic reduction overall in all the trials of telemonitoring in the world literature. We've got data on 21 trials, individual patient data in our BP Smart collaboration, which we're just about to submit for publication. And so this is a sneak preview. This time this is about control of hypertension. And what we've done is we've grouped trials, and these are not all telemonitoring trials, but I've circled 3 here that are telemonitoring trials. This group are basically just self-monitoring on its own. This is self-monitoring with a very basic thing, in this case, basic telemonitoring. This is telemonitoring with more stuff, wearable education or self-management in our case. And this is telemonitoring with full-on pharmacy support. And as you can see, the more you do, the better result you get. And this is just telemonitoring on its own. So on its own, it's not a magic bullet, it's what you do with it. In an NHS context, does telemonitoring actually add anything to self-monitoring? Well, I'd argue that it's not necessarily clear. We're currently recruiting for the Tasman 4 study. We're about 600 patients into 1,100 we're trying to recruit. Maybe at a future BHS meeting, I'll be able to share with you those results. So just to conclude, those questions we ask, those theoretical things, feedback to the physician, well, telemonitoring does that, but it's not enough on its own. Does it promote the doctor-patient partnership? Yes, it seems to. Information management issue, I didn't really talk about integration, but it's been raised in the previous talk. Most GPs use electronic health records. Most telemonitoring systems are standalone, and we need to work out a way of fitting that together. Automatic feedback's possible. You can do novel things, which again I haven't discussed, but it's definitely possible to do things like blood pressure variability, which we can maybe discuss. Reduce Carer burden, well, I don't think that's necessarily clear. And does it give better control than self-monitoring? Well, I'll tell you in a couple of years' time. And that was all I was going to say. Thank you very much.
Thank you very much, Richard. Very clear presentation. Are there risks, are there medical legal risks if data is sent in, particularly if a patient sends in symptoms and there's no action for a certain period? Who's liable, and does that occur?
So I can't give you figures on how much that occurs in telemonitoring. However, I can tell you that in studies of normal practice, forget about telemonitoring, only between 8 and 50% of the time, depending on which study you look at, do people act on normal blood pressures written in the notes. So what we're doing currently is largely ignoring raised blood pressures that are being carefully recorded in the clinical records. And this is not just GPs, this is GPs, and they've looked at it in physicians, they've looked at it in hypertension, diabetes and stuff. Doctors in general ignore raised readings, and we've all had the conversation, I'm sorry doctor, I must have rushed, I was late, I've just done whatever, my pet's ill, or whatever the thing is, and we all come to the decision that we're not going to act on it. So I think it's likely that telemonitoring is probably going to give results that maybe we don't act on. One can, with telemonitoring, set up alerts, so you get a text as a physician saying we've got a high reading, are you going to do something about it? But in general, I think the issue is not to do with telemonitoring, it's to do with physician behaviour in reacting to raised readings.
Questions from the floor. Philip?
Do you have pre-treatment rules about what should be done? Because what I've noticed is over the last year or two I've been not telemonitoring, but getting my patients to send me emails of their last 5 days readings regularly. And of course, one, they're very encouraged, especially when I write back and adjust their therapy. But the numbers are cumulative. And suddenly it becomes a burden which I hadn't bargained for. And I'm only responsible. And I just wonder how, if you do this, unless you've got prior rules or automated rules, it's going to become a burden, which to me it's already becoming.
So I think that this is definitely true, and I'm not sure that this is anything specific to telemonitoring. It's to do with the way that we're working. So many GPs, a standard GP clinic will be 20 patients, and then there'll be the phone calls. I was talking to one of my colleagues who regularly gets 10 phone calls at the end of her 20-patient clinic, and then you get your emails, some of which may include blood pressures. And at the moment, we're being very bad as a profession at giving ourselves time. Many practices don't give you time to do the phone calls, let alone the emails, and it's exactly the same issue, that we have to be sensible about it. I agree with you that automated systems are probably the way forward, because if it's fine, you can just have an automated email to the patient, yeah, that's fine, carry on with your medication with a copy to the GP, and then flag up changes to make. If you use a system like we did in the Tasman studies, at the beginning you can make your decisions about what medication changes a patient's going to make, and then they can get on and make it. And I'd argue that for a proportion of patients as well, that is a way of reducing workload. And in the trial, the consultation rate was not significantly different in those in the telemonitoring group compared with those in usual care.
Simon Thom.
Richard over here. Is it fair to say that the principal impact of telemonitoring, telemedicine, is that it truncates the time taken for the individual patient to get to the correct combination of medication that produces control? And might you not get to that same end quicker by simply kicking off at the point of diagnosis with combination medication in a single pill?
Yeah, no, I think that that's quite right, and I think that that this isn't magic. This is about better use of medications. I think what it does, if in terms of self-management, is it allows the patient to be in control, and so I think probably the reason it worked is that the patients were, once they understood what they needed to do, they were happy to get on with it, and they did it largely following the rules more than we do. There's good data. There's a great trial from 1979, which hardly anyone knows about, which randomised about 1,000 patients and just showed that structured care, nothing complicated, just seeing patients every month, titrating them up if they have high blood pressure and going on like that, actually showed a mortality benefit in the people who had structured care. No one ever talks about this. It's not rocket science. This is just another way of getting control quickly. And I agree with you that a combination therapy may well do that as well.
Rory?
Just to follow up on that, because there is the question, the problem these days with pharmacogenomics of a combination pill is that you may be taking parts of that pill that are not very useful for you. So in your telemonitoring, do patients, when they take a drug that does not work, that there's no effect on systolic blood pressure, do they stop that drug?
So in this trial, we didn't build in stopping the drug. We were just trying to keep it simple, and so we just added on medication unless the GP decided to intervene over and above that. I agree with you. I mean, it'd be fascinating to see if one could do that. I think that and I'm no expert in genomics by any means, but if you're going to have the key thing in general practice would be to have a system where you can have pharmacies able to dispense these multiple combinations in a way that's not going to confuse people. And if anyone is familiar with treating people with multi-morbid conditions, which quite a few of our patients are, when they're on 10 or 15 other medications, then we've got to be very careful not to get very confused, I think.
Okay, and one final quick question.
Richard, was there an upper cutoff point at which you wouldn't have included these patients into the trial, for example, systolic blood pressure of 180?
Yeah, so sorry, we didn't randomise people who were 180 over 110 or more. We sent them straight to their GP to be sorted out quicker because we didn't think it was ethical. In our meta-analysis, we've looked at people who had very high blood pressure who actually get it with self-monitoring get a decent amount of effect. The people that these sorts of interventions don't really work for are the people you might expect, so the people on 4 or more medications where they're probably not taking them in the first place, so adding additional medications, it doesn't make much difference.
Thank you very much.
Okay, thank you.